Hello, this is Dr. Ahmed Abdelal, and today we are going to speak about fluency disorders, that is, stuttering, and a disorder you might not be familiar with called cluttering, but we'll speak more about stuttering. I'm sure you have seen uh, many people who are famous who stutter. And just upfront, stuttering has nothing to do with intelligence, with being smart. There are some people who are geniuses and they stutter. It's just a matter of a neurological problem that has to do with regulating breathing, with muscular movement, moving the muscles for speech, and regulating. Because the process of speech production is quite complicated. Just to produce a single word, you have to use about 93 muscles. And these muscles, they work in groups, and each group has to work in coordination with the other group. Because when you say a word, you have to say a certain sound before the next one, before the next one, and some sounds are produced kind of simultaneously with ones that we are going to say. Anyways, um, speech production requires not just um, saying sounds, it requires all these muscles to work together so you can coordinate the way you are breathing with the way you are phonating, with the way that you are articulating, and all of this with the way that your brain is planning the motor movements, the scripts for the behavior, for the action, for your linguistic, what you want to say linguistically, and for the map, for the motor map and motor program that needs to be executed into movements. So it is a very complex interaction, and it is not doesn't have anything to do with cognitive, acuity, for example. So um, first, fluency as a definition. Sorry. Fluency is the ability to produce speech that is effortless, that is rhythmic, because speech has a natural melody, rhythmic. You go higher pitch, lower pitch, higher loudness, lower, and it just goes in a musical way by nature. And that flow is uninterrupted in an abnormal way. In other words, as we speak, we we release a column of air out. We speak um, following or using the air that we are inhaling. And as we do that, we coordinate the amount of pressure that we have and the amount of air we have in our lungs with the muscular forces that we have in our thorax and laryngeal systems and so on, and control that air so that we chop it, we kind of, as it goes, we chop it into sounds and words and sentences, and within between words there are tiny pauses you are not always aware of, and between phrases there are little longer pauses, and then like marked by a comma when you write, for example, and then the a long kind of pause is the stop, is the period that we, so the punctuation we use in writing is a reflection of the pauses that we produce in speaking, that we call this juncture. So these are internalized. So as we speak, we, as native speakers of a particular language, we kind of have this natural pausing, and based on the amount of air we have and based on how we breathe, and we coordinate our breathing with our ideas so that you can produce, for example, one sentence within one breath, for example. So also we coordinate this with swallowing, as you know, the sentence and whatever we say, it's coordinated with swallowing as well. Disfluency is the opposite of that, obviously. A disfluency is any kind of interruption or disruption that causes speech to lack rhythm, that causes speech to be effortful, and to kind of not to flow naturally and spontaneously. So a disfluency could be the repetition of a phrase, like the cat. The cat is a phrase. The cat went. So the cat. That's a phrase. The repetition, for example, of the interjections, like we call them gap fillers sometimes, or interjections like uh. So you know, stuff. So a lot of things that people do that really have no meaning whatsoever. So when someone says, what does that mean? You understand me? It doesn't. A lot of these things have no meaning at all, and the person is just saying them as they stall and kind of try to buy time. So these gap fillers or interjections can be quite frequent, and also pauses and sentence revisions like this. I want to go to the store. I want to go to the store and buy some. I want to go to the store and buy milk. So the person begins and somewhere just goes back and restarts a sentence again. And these are called sometimes sentence revisions or false starts. And the purpose of this, or usually the reason is, could be one of two things. That the person has word retrieval problems. And as he or she thinks that they are coming to a word they do not recall, so they just go back and try to find another word, for it. Or that they know that this word that is going to come somewhere in the sentence is hard for them, and that they, whenever they see it, they stutter. They go and reverse to find another word. And then a sentence, in addition to these, we have repetition of words, repetition of single sounds. And these are very specific to stuttering. A lot of what we have here, all of us, any one of us, no matter how intact your neurological system is, we exhibit some of these. And we exhibit them more often at certain times. For example, if you don't sleep enough, if you are tired, if you are stressed, and so on, you experience more of these than other times. But the idea is, when these become more than 10%, when they exceed the kind of 10%, they disrupt your work, they disrupt your social interactions, they become noticeable, and this is where they will be diagnosed as a disorder. And that is almost like a rule of thumb for diagnosing any mental disorder. I'm saying fluency is a mental disorder in the sense that language is a mental process, that speech is a mental process, and that these disorders of communication are classified in the Diagnostic and Statistical Manual for mental disorders. So anything that you do is basically the product of your brain. So fluency disorders include stuttering and cluttering. I briefly discussed cluttering at the very end, and we're not going to spend too much time on it, especially because it hasn't been officially recognized in the DSM, Diagnostic and Statistical Manual. It hasn't been officially recognized as a disorder. So stuttering has been here for millennia, for thousands of years. Stuttering is a type of speech disorder characterized by an unusually high rates of repetition, prolongation, and blockage that interrupt the flow and rhythm of speech. So that these three pieces here are significant, and all the evaluation, all the treatment are going to target these three: repetition, prolongation, and blockage. So I'll give you just a quick example of each. Repetition could be the repetition of a phrase, of a word, of a sound. Sound repetition is the most difficult one that is particularly specific to stuttering. When you see it, you call it a sign of stuttering. And prolongations involve making a sound longer than it is. For example, when you say Sam, so that is prolongation. Blockage. A blockage involves six sounds called the stop sounds, or the plosive sounds that we spoke about earlier. And these include the P. Notice all of these sounds stop the airway. When you produce them, they block, you close the airway completely. And then you release. So we have P and B, T and D, K and G. And then we have as when you say Ka N. So these are called the stop sounds. You block the airway naturally, and then you explode the air to make the sound. So people who stutter tend to just have difficulty opening up when they block. When they close for these stop sounds, 7 stop sounds, they have difficulty just releasing the blockage. And they would make it, we call it a block when we say K. So these become blockages. The stop becomes a block, and only involve the 7 sounds that we know as stops. So stuttering generally has a great significant effect on the individual, depending on age. Of course, young children are not particularly very aware, unless of course you keep bringing it up to them, and you should not. But soon the child becomes aware of the struggles and aware of people's attitudes and so on, and that is going to make a difference. So stuttering can negatively impact the person's communication. It will make the person kind of have less motivation to communicate, and in some cases avoidance of communication situations. It causes or it is associated with self-esteem, lower self-esteem, and lack of confidence, and that you can imagine will cause frustration. In terms of how common stuttering is, around the world, 1%, every 100 people one of them will stutter around the world. So now let's look in terms of numbers. If you know in America, for example, the American population is 300 million, 326 million, for example. The number, I haven't checked the most recent number, so you can go to the world, the US population clock and find out exactly the number of Americans, how many Americans are in America. And then you can get the number of people, like how many million Americans stutter. You need to know this for the quiz. So stuttering is tilted more kind of toward males. There, for every 3 males, there is 1 female. So the ratio is higher for males than for females, for reasons that are not yet known. The cause is exactly, again, there is no specific cause that says this is the reason why people stutter, but the common belief based on the research so far done is that stuttering is the byproduct of the interaction between some intrinsic factors in the neurological makeup, in the genetic makeup of the person, and external factors. We know that the field of epigenetics that focuses on external environment as a way to activate or activate or deactivate genes. So the environment has a great effect on how genes express themselves. So that is the idea is that stuttering is caused by an interaction between environmental factors and intrinsic factors within the person, like genetics and neurological makeup. So now, as I mentioned, many of us experience disfluency, and probably you can count in my lecture today, you can count as, so many disfluencies, and that is totally normal. But when it exceeds a certain rate, it makes it stuttering, for example. And when you look at the kind of stuttering or the kind of, disfluencies, then that also will make a difference. We said that the specific stuttering behaviors include the repetition, prolongations, prolongations, and the third one, blockage. So these are specific to stuttering. The other disfluencies, these are the kind of repeating bigger, like words, for example, and repeating sentences or phrases, the ones that we spoke about, the gap fillers, and so on. These are disfluencies not necessarily limited to stuttering. And the evidence, as I mentioned, is that many people, all people, do exhibit that once in a while based on, who they are. So there are, for example, some characteristics that distinguish people who stutter. They tend to have a slower reaction time, like when you speak to them, for example, it takes a little bit more time to activate, and also may they seem to have a less efficient neurological system, motor system, not the whole system, of course, but in the areas that regulate communication. But they're overall, like movement and stuff, other than speech, is totally fine. Research shows that the right hemisphere is more involved, shows more activity in people who stutter, and also the cerebellum in back of the brain here that shows more activity. Both, of course, are involved in speech. The cerebellum has a lot to do with monitoring movements and motor commands and matching them with the intended, with what you want to say, and identifying errors, any mismatches between what you want to say and what the muscles are doing. Any mismatches, errors are identified by the cerebellum, and the cerebellum is going to communicate with the motor cortex here and with the frontal part of the brain that regulates your intentions and gives you the purpose to talk and so on. So the other thing is that the right hemisphere is involved. So the right hemisphere is engaged in looking at the whole picture as a whole, processing the situation that you are in, and the situation of a story or a book or just a holistic picture. Now, the reason that these areas are more active in people who stutter is that when you have a task that is hard and you're struggling with, you tend to exert more effort. You have to deploy more energy from areas that are commonly not as involved or not involved to that extreme extent. So this is a kind of compensation for what the person is trying to do. Yeah, for example, you might try to hold, pull something, and both hands are not enough. You might hold with your teeth. You might hold with your feet, or so it is a way to compensate, but it shows that again, these areas, again, they show that the extent of effort, extra effort, that people who stutter have to exert. There are two kinds of situations for people who stutter. The development of stuttering begins at age 2. You wonder why age 2? Age 2 is so important. We have spoken about age 2 for quite a while now. 18 months, age 2. That is the time when the child is going to have a vocabulary spurt. That is the time when the upper layers of the cortex make pathways to go deeper to connect with lower layers of the cortex. And now you have long-term memory tracks, and you are able to remember more. You are able to use that memory to produce sentences and to kind of expand your vocabulary and to monitor your behavior. A lot of things happen at age 2. So at that time, while all of this is happening, the child, some of the skills might be developing faster than other skills, and the neurological system, different parts of it are kind of developing at different paces and so on. As a result, people who stutter, they begin around age 2, and they might, some of them a little bit later, but between ages 2 and 7, and especially the younger, particularly 2 to 4 years of age. That's the greatest majority. So let me clarify. People who stutter, when you look at them, they developmental, they start between ages 2 and 7. Okay, so let's say 1% of the population in the world. We are talking about that 1% of the people in the world. They all, they started stuttering early in life between ages 2 and 7. Stuttering does not begin after age 10 or 12 years. It doesn't begin developmental. It doesn't start at that time. It is unlikely, very, very unlikely, unless there is a brain damage or some kind of acquired problem. So now, the of this group, 50% of these people, the 1% that we are talking about, 50% of them, half of them, they have genetic causes. And 15% of them have first degree relatives, like a brother, a father, a mother, an aunt, who are stutterers. 15%. And some have, somewhere in their genes, whether expressing it or not, or some distant member of the family. And there's a video for each. Please watch the videos and take notes. And then there is the acquired kind, which can be caused by a wide range of neurological injuries, including strokes, including certain neurological diseases, and also sometimes stuttering can occur temporarily as a result of certain medications. For example, I had a case, a child who was 3.5 years old, and I had been seeing him for speech therapy for quite a while, and he was totally okay. And then the parents at some point in this came, like in March, came and said, he's stuttering, we're very concerned. And I kind of said, don't mention it to him. And I listened to him as I was speaking, and it was quite a shock that was suddenly appearing. That was very, very unlikely that it would be the developmental stuttering. So I said, is he taking any medications? They said no, but he is on Zyrtec. So I immediately got on the phone. I first did my search on to see if there were any side effects. There were none listed. I called Zyrtec, Pfizer in Canada, and they said, well, there are no symptoms listed right now, but wait a few minutes. We're gonna check the data we have not yet published. And they checked the data for the past 3 months, and they said, yes, we have some studies showing that the Zyrtec has pseudoephedrine that will have a negative impact on children who are young, on the neurological system of children who are young. So I informed the physician and the parents, and they stopped that Zyrtec, and the child took about 3 to 4 weeks, and the stuttering disappeared. So it is important to check and make sure, ask about any question. What is the person taking? Any medications, any supplements, any whatever, and you go and do your search, and you might find something. That is if the stuttering appears suddenly, for example. So now we get into detail. So generally, 5% of children ages 2 to 7 experience some form of stuttering. And of these 5%, okay, those who stutter during childhood between 2 to 7, 80% of them will recover, will grow out of it within 6 months. No speech, nothing. However, if they are males, because the ratio is higher for males, you need to pay more attention. It becomes, and also if you look for other signs and see that they have a relative who stutters, you need to monitor closely and to give suggestions and tips and so on. So in the end, 20% of those who stutter between ages 2 and 7, 20% of them, 1/5 of them, they continue to stutter throughout life. They are the ones who make up that 1% of the world population who stutters. Okay, so here is the link to an article that is you'll find it quite informative. So factors that contribute to stuttering include teasing, people's reactions and attitudes. When you notice when people are struggling and trying to say something, people tend to put words in their mouths. They tend to they think they are being compassionate and helpful, but they make the person more nervous. The best thing you can do is to simply just wait, be quiet, and listen and focus on the content of what the person is saying, not how the person is saying. So people's attitudes and reactions are important. Family rules. If there are very strict rules, disciplinary rules, you have to keep your room immaculate. You have to be just basically walk on walls. These very rigid rules can make the person quite stressed. And also disciplinary methods. So the way that the environment, we receive input, we receive stimulations, we hear things, whether these things can affect our emotions, will affect how we think and behave, and so on. And when, say, a child wants to speak to his father, for example, and every time the father just busy and rushing, or the mother, as a matter of fact, and the parent is busy and rushing, and okay, just to tell me, I'm really busy, what do you want, and do you mean this, and they start putting the words and in the child's mouth, and they start, that child, every time he goes, now he is gonna look and imagine the situation again. It will create an association in him, that attitude. It will make him avoid the interaction, avoid going and interacting with the adult, and gradually that avoidance will make the child stop exercising and practicing the muscles of speech, and as a result, that is going to make the problem worse, in addition to establishing negative associations that are going to trigger the stuttering behavior and will make it stay longer. And the opposite is true. So if someone continues to experience a positive reaction, that will make the severity less. So again, the interruptions and the threat, and if the child is feeling threatened in an environment when he or she goes to communicate, these experiences over time will make the brain develop associations and establish networks that will be associated with negative behavior that is gonna activate the faulty ways of speaking. And the opposite is true. When someone experiences a positive environment, even if that person has genetic predispositions, that person will practice more, will feel safer to speak and not to be judged, and that is going to make the problem less severe. So there are indications of indicators of early stuttering, and I am just going to clarify a couple of these. You can go over them. I don't want to make the video too long. So if the person, of course, has 3% stutters, 3%, especially focus on repetitions, prolongations, and blockages, and the average, for example, three or more stuttering, like disfluencies, for example, like syllable repetitions, word repetitions, sound repetitions, prolongations, in 100 words. That is also 3%. So the stuttering-like behaviors and the true stuttering behaviors, 3% each. 72% of all the stuttered, of all the disfluencies that the person makes or exhibits, 72 to 75% of these are true, like stuttered behaviors, whether they are disfluencies or particular stuttering behavior. And then 25% of these 25% or more of the total disfluencies involve prolonging sounds and blocking, like blocking and prolonging sounds, 25%. And there's always like a fluctuation. Sometimes the person stutters more, sometimes stutters less, depending on events and situations. And also there are secondary behaviors like blinking, closing eyes, jerking around the lips, jaw jerking, facial tics. So these are a big sign as well. And the feeling, the person is aware and feels frustrated. So these are just highlighted here from this list, and they include 3% or greater, as a rate, and 25 of the total disfluencies are audible prolongations. Like you hear them like you can hear them. The increase over time and the excessive tension or struggle during stuttering that usually show signs of frustration. So now the 20% of the people who continue to stutter throughout life, those one that make up the national like the human population, 1% of the human population, these we call them chronic stutterers, those who stutter throughout life. So they start stuttering developmentally between ages 2 to 7 and they continue throughout life. Factors that can cause them to continue and not recover include negative feelings and attitudes, for example, being self-conscious because of the attitude that people show to them, because people are impatient, because people are over-judgmental, and also avoidance. For example, they avoid certain sounds. They know when they come to the maybe each one has particular sounds and words that they particularly feel they have a tough time with, so they tend to avoid them. So we say words like give me the same thing, give me the you change and say I want something different, for example, or I want something that's like that. So also certain situations, for example, usually before transitions. I worked in the school system for 12 years and in clinical practice for many years after. And I noticed individuals who stuttered, they had a tough time before and after transitions, major transitions. There is, for example, a long week, a long holiday, long weekend holiday. They before they go into it, they stutter more. After they come back they stutter more. Before major holidays, because during these situations they are gonna meet more people, they are gonna face newer situations, and that will increase the stress level, and that is gonna make the stuttering worse. Difficulties with speech motor control. Breathing is one of these things that you need to take one breath, and as you release it, you again rhythmically stop at certain, block the air with your articulators at certain positions and in a systematic way. So people, they tend to have difficulty regulating their breathing. For example, releasing the blockage, for example, making it, longer, releasing stop sounds. Difficulties with language formulation. In some cases, I evaluated a person many years ago, and I found that one of the underlying causes for the stuttering was that his language was poor. And I worked with him strengthening his language abilities and also increasing his fluent behavior, and that he was a success case. It was fifth grade. He was very, very successful, and eventually went to the Navy, and he wrote to me after. That was really so nice. So difficulty with, it is when we do a stuttering evaluation, we evaluate vocabulary and language, because they could, when someone doesn't have fluent grammar and that doesn't have a lot of words in their vocabulary, they will stall and they will be very disfluent. So you need to isolate that. That is different from the chronic stuttering or the developmental stuttering that is related to genetic factors. In terms of the behaviors, what the person does that will make him or her a stutterer, there are two sets of behaviors. One set is called the primary. That involves the language, how the person actually says, produces the sounds, for example, and the words. So the language itself. That the number one, repetitions. The person would repeat, for example, words and sounds. These are the most difficult things, especially sound repetitions. When they go tools, things like that. So these are the hardest ones. You can easily eliminate word repetition. You can easily eliminate phrase repetition. The bigger the repetition, the thing is that you repeat, the easier it is for you to take it out, to stop that behavior. But sound repetition tends to be quite persistent. So 3 to 4 repetitions at the beginning of certain words. For example, I want to go to the store. I want to go to the store. So 3 to 4 times. Prolongations, making sounds that you can continue, like smile. That most of these sounds you can extend, so they tend to be like so and then you can hear these sounds as they become, the person is just continuing to say them, you can hear them. And then the blocks, that was supposed to be highlighted like this, but just with the formatting. So these 3 characteristics: repetitions, prolongations, and blocking, or blocks. Then the secondary characteristics include what the person does that is not part of speech, that is a sign of whether nervousness or struggling as they try to talk, like eye blinking, jaw jerking, lip protrusions, changing words, like when I say I want to have the same thing, can I have something like this one? So you change same, replace it with like. But that will involve reversal. That will also cause the sentences to be chopped and the person has to restart again. Changing words, flapping arms sometimes with little kids, pressing eyes closed tightly, tensing corners of the mouth, tilting the head when blocking. And some people um, kind of exhibit more of some of these than others. So each person will have their own set of um, movements that characterize the secondary behaviors. There is a lot of variability, obviously. Some people have very mild stuttering. Some people have a severe form. Um, some people make longer prolongations, longer blocks, and so on. So it varies, like any disorder has severity levels, mild, moderate, and severe. So the typical duration is 3 seconds. For example, for sounds, it can be longer. When you make a particular sound. Um, the thing that fluency decreases and sometimes is okay, it just keeps changing, and the person feels he or she has no control, leads to that arrow is like in the chemical equation, means it leads to, it results in. So whenever you see that arrow, so the peaks and valleys of fluency lead to frustration and also the pressure the person experiences, the pressure, social pressure that he or she has to be fluent, especially in the Western culture. I mean, fluency is highly valued. So that pressure will lead to greater disfluencies. Like say, you want to go for an interview. When you go for an interview, that's a high stakes kind of meeting. You will become nervous whether you stutter or not. And the person who stutters, of course, will experience a very, much harder time. But there are situations when the person doesn't stutter at all, or doesn't stutter as severely, for example, when they sing or act, and you wonder why. Because can you sing a song that you do not know the words and you memorize the words? Or look at them, or act. What do you do to act? You have to memorize your role. So you have this already, no surprises. Earl, what's his name? Forgot his first name. The one who does Simba's father in The Lion King, and the one who says, "This is CNN." He stutters today. I mean, he grew up stuttering, but as an actor, you would not notice it. It doesn't exist when he acts. Using pretend voices or accents, talking to babies or animals, or when the speech is masked. If you haven't watched The King's Speech, please do. It's a really, really very good movie, and we as speech pathologists encourage people to watch it because it is all about stuttering. And when the therapist gives the king headphones and plays music, loud music, so that he himself cannot hear his own voice, and he asks him to read. And then the king is like, "What is this? This is ridiculous." And he keeps reading. And then he just takes off the headphones, throws them down, and just throws that book and just walks out and says, "This is not working. I can't even hear myself talking." So eventually he sends him that big CD and he's just finds that as he was speaking fluently. And so, anyways, masking does make the person improve fluency quite a lot. Avoidance behavior, as I mentioned, it involves avoiding certain sounds, certain words, certain situations. So, and because the person has associated these with negative experiences, and the nervous system got used to that, and like, anything that excuse me, that the person does or doesn't do, negative behavior or positive, that is taught through something called conditioned learning. Conditioned learning. The same, or called operant conditioning sometimes. The same thing based on that experience Pavlov did with the dog when he took a piece of meat and showed it to the dog, and initially he got a bell, and every time he would show the meat, he would ring the bell, and eventually, and the dog will salivate. Eventually, that meat, he didn't show the meat, he showed the bell, to rings the bell, and the dog will salivate. So that is called conditioned learning. You make an association. The bell has nothing to do with food, nothing to do with any, food. Yet you got the food and associated them, presented them at the same time, and then as a result, whenever that dog saw heard the bell, it made the networks in his brain that have to do with food activated, and that is conditioned learning. The same thing happens here. When the negative experiences occur, the person associates that. I have to rush a little bit because I don't want the video to stop like last time. So consequences, when the person avoids these situations and sounds and words and so on, he or she doesn't practice, doesn't exercise. The more you use your articulators, the more fluent, the more comfortable, the more, so the more skilled you are. So that avoidance behavior makes the stuttering worse, and the person then develops the feeling that stuttering has control over him, and the avoidance also means less practice. So it causes the nervous system to be conditioned, and you want to break away from that. The people who stutter tend to have difficulty regulating the motor system. I mean, motor system that controls speech motor system. And that leads to irregular breathing patterns. So part of the treatment will involve regulating that breathing in and out in a gentle, smooth way, releasing the blocks in a smooth way, and easy onset. In terms of evaluation, when we evaluate, we also look at language, as I mentioned, and the assessment, the goal of the assessment is to identify first, is this person a true stutterer or just a developmental stutterer, for example, the one who is going to grow out of it. Describing the patterns of disfluency, listening to the speech and identifying the percentage of stuttered words and syllables and so on, and identifying how many are blocks, how many are repetitions, how many are prolongations, and so on. These are the patterns. To determine the most effective way for treatment, because diagnostics, the assessment provides you like with the major areas that have the problem, and also will give us an indication about how to proceed with treatment. We look at the case history. It's very important to have a very thorough case history that speaks about pregnancy, drugs during pregnancy, any kind of metal exposure, very, very thorough case history that goes again from pregnancy throughout the time that the person sees you. And we also want to determine environmental, kind of as much of the aspects of the environment as possible. Ask about anyone in the family who also had experiences with stuttering or is experiencing stuttering. Like in some cases, I get the statement that, oh, his father used to stutter when he was a kid like him. So, but now his father is not stuttering. So that is a good indication in some way. If the stuttering changes over time based on the situations, based on transitions, also the perception of the family, how does the family feel? How concerned are they? What are they doing at home? Because if they are becoming the therapists at home, that could not be always good unless they are trained to do so. The person's reaction. So, in terms of the procedures, how we do that, we first have the interviews with the parents, teachers, if the child is old enough to go to school or preschool. We look at the case history again, beginning from pregnancy. We take speech samples. We want to sample the child's speech in times when he would have a tough time with speaking, in areas like in say a preschool, for example, or a school, and a home, on the street, or somewhere, or in the office, in different situations at different times. So you want to see how the behavior changes. Um, Language development is always important to evaluate. We look at consistency. How, when you say the child is stuttering and has blockings or blocks, so does he always have that with every time he say, for example, he blocks at the t or the k? Every time he sees the t or k, does he always do that? Is there consistency? Does he do the same thing? Or series is waking up. Does he do the same thing exactly in every situation? Adaptations. When he starts to have this experience, the disfluencies or the stuttering, what does he do in like trying to cope with that? The feelings and attitudes of the person. And then what kind of techniques are you gonna give at the beginning to see how the child or how the person would respond to what you do? The speech sample is typically 300 to 500. The more words you get, the more accurate your results are. It's like flipping that coin. You can flip it once and say, oh, or flip it twice and say, oh, 50% I got heads of and 50% tails based on 2 times. But if you get it 1,000 times, you are gonna get more accurate predictions. So in any case, a sample less than 100 words is not good. It's not going to give you good results at all. So between 300 to 500, that is something that I do, and it gives a lot of information. We look at the percentage of disfluencies out of that sample, the percentage of stuttering like disfluencies, like repeating phrases and things that are longer and can be easily treated. Looking at the person's attitudes and feelings indirectly, instead of asking, "Are you frustrated when you start?" Of course, you know that. You say, "Yeah." No, you want to ask open-ended questions. You want to ask questions like, "Explain to me how exactly it is when you are trying to say something and it just doesn't come out," and then leave that open, and then you can interpret the attitude instead of kind of asking simple questions. There are, in addition to the case history and the things I spoke about, these are tools, assessment instruments that are available in the market that we use with different, categories of people. For example, the stuttering severity index is for adults and children. There are ones that are particularly for children. So we use that, and we use, other things like questionnaires to parents, teachers, and people who know the child, and excuse me, we use case history information as well and interviews. So we take when we look at the sample, we do a statistical analysis of the sample. And we, for example, the sample I spoke about, say 500 words in total. Let's say you get that sample, you count the words 500. And so you look at, say you get 76 words that involve stuttering. 76 of these 500 are stuttered. You divide 76 by 500, and then you times 100. That gives you 15.2%. So that is significant. That's over, the minimum. So percentage, then you take that 76 words, you take that, which is 15%. You take that and say, for example, how many words of that contain sound prolongations? How many of them contained were sound repetition? How many of them were blocks, involved blocks? Let's say prolongations. So making the sound longer. 21 words out of the 76, for example, were prolongations. So you get 21% divided by 76. That is the percent of prolongations in the stuttered words. So we go by that and we identify the severity based on data that we have. The criteria for stuttering here is that you diagnose someone with stuttering if the total disfluencies, total, including stuff like, and total is 10% or greater. And that is consistent with any kind of mental disorder. Disfluencies, these disfluencies, for part word repetition, like when one sound of a word or two sounds of the word are repeated, or for sound prolongations, or for broken words, 3% or greater. So that these are the particular stuttering, the true stuttering signs. And then the average duration of the disfluencies, on average, each disfluency is 1 second or longer. Most disfluencies, disfluency types are restricted to like one or two sounds of the word repeated several times. Monosyllabic whole words, for example, like door, at, to the store. Excuse me. Sound prolongations, silent pauses, and broken words. So the presence of secondary behaviors as well, if these are present, and if the client, that is not very important, but it is included as well. But the true signs are these. If these are here and this rate is there, you diagnose the person with stuttering. And we look, obviously, if the child is very young, might not be aware, he or she might not be aware. And if they will exhibit frustrations and sometimes avoidance. The treatment, there are many different kinds, but generally there are two big approaches. Stuttering cannot be cured. We have no cure for it. What we do is to give the person tools to have better control over fluency of his or her speech. It is like someone who stuttered. She said, and she was doing quite well. She said, when I speak, I am like someone who is speaking a foreign language, a second language. I have to think about everything that I say and plan it before I say it. When I do that, I do quite well. So that is, she is saying that she used the techniques in order to increase her fluency, to have control over her behavior as she speaks, and that is making good results. However, you and I don't even think about what we are saying because we are taking this skill for granted. So we teach people techniques. These techniques do work. They take different, time durations with different people based on how severe the problem is and so on. But we do not have a cure. So the treatment goal is to increase the person's control over the speech fluency. And the two major approaches are, one is to work on the stuttering itself and try to delete that stuttering. One says, no, I'm gonna work on the full half of the glass. I'm gonna take the fluency that the person has, the strengths that they have, and I'm gonna build on that. I want to increase the fluent behavior, and by increasing the fluent behavior, I'm simultaneously decreasing the disfluent behavior. It is like saying, I have 50% of something, you have 50% of something. Now someone comes in and takes one thing from you and gives that to me. That, even though now we are equal, before that we were equal, and now you take one item from me, now you are left with 49. What do I have? I have 51. I am 2 points above you now. So just simply by taking one thing and putting it on the other basket, you make the other basket more, but you make the other one, the opposite one, less. So that's the idea. Increase the fluency, simultaneously that's going to decrease the disfluency. So these are the two major approaches, and one of these stuttering modification, it has all these steps. One is motivation, working on increasing the person's motivation to speak, and focusing on identifying the words and the things that the person has a difficult time with. Like, for example, I work first on eliminating phrase repetitions out of the way, and then word repetition out of the way, and then focus the rest of the treatment on the sound repetition. So desensitization, taking words and kind of trying to break up the negative association between words and bad situations. Variation, for example, of the different ways of saying the same thing. Approximation, come as close, say this as closely as possible to what how you should say it. If you can't say smile, it's okay to say smile, make it a little bit longer but not as long, but you gradually pull back. So pulling out when you feel that you are coming to a situation where you just can't stop the block or the stuttering situation, just stop it completely, stop talking. Preparatory sets, making scripts. I'm going to McDonald's, I'm going to a store or a restaurant, say, to order something. I don't want to promote a place by name. And so I plan, this is what I'm going to say, I rehearse it, and then I go and I have a better chance of doing better. Stabilization, I continue to practice the things that I already know until I'm stable in producing them. Stuttering modifications, again, these are the goals. I'm not going to read them, just the video is getting to be too long. The major techniques include cancellation techniques like stopping, pausing, repeating, pulling out of, just completely stopping. And that is more about the pulling out technique. And then fluency shaping, it takes the fluent speech behavior and tries to make the person work on making yourself more fluent. than focusing on the disfluencies. But in the meantime, you are working really on both. So the one that works best for children is a combination of the two, where the fluency shaping is more of the fluency shaping combined with the stuttering modification, and you work with kids, focusing on a lot of techniques. For example, one summer camp on stuttering, the therapists would get balloons, and they would work with the children and say, "This is your stuttering monster. He's the one who causes you to stutter." And they work and work and work throughout the summer. At the end of the camp, now the children have achieved a lot of progress, and each one has a monster on the balloon, and they go outside and all say goodbye to their stuttering monster. They get rid of their stuttering monster, and they just let go of the balloon, just goes away, and then the person feels now, oh, I don't have that stuttering monster anymore. I am doing good. I'll continue to speak fluently because that stuttering monster is gone. So that is just one. Whether that works long term or to what extent, I don't have research, but I have seen it in some conferences presented. We work closely with the family, in addition to the child, and we again try to make the rules less rigid, trying to teach the adults how to focus on the content rather than being judgmental and showing the child what to do and saying, oh, breathe, stop, pause. These are the worst things you could say to an adult or a child. Just listen and focus, ask questions, follow up questions about the content rather than attracting attention to how they speak. As far as adults, one of the approaches that is quite effective is cognitive behavioral therapy, and that is basically a way to retrain the program and program the brain so that it can break away negative associations and promote newer ones. And it has a particular system. It's very rigorous. It takes about 4 months to get the techniques done. It involves a lot of practice in therapy and every single day out of therapy. And there's a lot of research to show how it is effective with treatment of stuttering and ADHD and depression and a lot of other disorders. But it has to be implemented very, very accurately in a specific, rigid way. There is the Stuttering Foundation of America. It's a very valuable resource. It gives you free books, free software, made for physicians, for parents, for people who stutter, for a lot of resources. They have like more than 20 books and pamphlets and publications, and they're nonprofit. They will just give that for free on their website, or if you want to have the hard copy, you can you just pay the shipping, they send you the stuff. For treatment, there are other programs that people follow. Some of the programs, I can't name every single program. The Lentcomb and the demands and capacities model. These are two programs people use. Lastly, for cluttering, that is a disorder. It sounds like stuttering. It is not stuttering. The person speaks very quickly, and the person just generally is cluttered and just has a fast neurological system, like hyperactive, and speaking very quickly, like chopping words all over the place. You can hardly catch up with that person. And there's a rule that says, as you increase the speed of something, accuracy will decrease. Definitely that will apply to all movements that we have as humans, especially speech. The faster you speak, the less accurate you're gonna be. There is no way you can get away from that. So these people speak very, very fast. Like the rate of speaking is about 160 words per minute or so. I counted for one of my clients 240, 230 very, very quickly per minute. And they are not aware of the problem. That's a major difference between them and stuttering. Please Google, go to YouTube and look for cluttering disorder or patient with cluttering disorder. So the person is not aware, while the person who stutters is quite aware and anxious and apprehensive. But the one who clutters is just not aware. People who clutter, their life tends to be cluttered. They are disorganized. They have a short attention span. They have perceptual weakness. So maybe a hearing loss. It could maybe just some perceptual, the way that the senses bring information in, they don't process that information well. Poorly organized thinking, reading and writing problems, lack of rhythm and musical ability, and restlessness and hyperactivity. These are things when we find the person exhibiting this fluent speech very quickly and chopping words and not fluent like that, and we look at these characteristics and they have them, we just say you have cluttering. However, cluttering as a disorder is not yet scientifically, it is not yet clinically recognized. So that's it. And sorry that the video was long, and if you felt I spoke too fast at some point, you can go back, luckily, pause, listen to it again, and I have to stop now. Thank you very much.